Okay, hello there. This is Dr. Marston, and we are uh, doing PTSD this week. This is week number 9, so we're moving on towards the end of the course here. Um, and today, the topic is going to be PTSD. Uh, I want to start, and of course, you read all through the chapter about PTSD and what it involves and all that sort of thing. But I wanted to start by making sure it was clear that PTSD. Okay, so I had to check something. PTSD is not the only diagnosis that can be associated with trauma. There are many other diagnoses um, that can have trauma as a factor. In fact, you could argue that every diagnosis in the DSM-5 could have trauma as a precipitating event. People often develop depression because of trauma. People often develop other anxiety disorders because of trauma. So, trauma itself is not only associated with PTSD. And I think that's an important thing to remember because it can often seem like um, PTSD is the only diagnosis that comes about from trauma. People will often talk about the impact of trauma by saying they developed PTSD. Whereas what they really mean is they were strongly impacted by trauma. And um, uh, there may be other diagnoses that come about uh, because of it. So, PTSD is not the only diagnosis to come about from trauma. It is a separate diagnosis because it is the one diagnosis that reflects that the person is essentially re experiencing the trauma. As you went through the chapter on PTSD, I'm sure you saw there how that was the issue. The issue with PTSD is what are factors that lead to the individual re experiencing the traumatic event? Because that's really what is at the heart of PTSD, that the person is essentially re experiencing the traumatic event over and over again. So the difference in, for instance, trauma causing depression or trauma. We talked last week about how reactive attachment disorder often comes about um, because a child experiences a lot of trauma at a very young age before they develop the abilities to speak and effectively communicate how they are feeling. And because of that, there is this very strong impact of the trauma. The difference between PTSD, which relates to trauma, and other diagnoses being associated with trauma is that PTSD is the diagnosis that reflects when the person is essentially re experiencing the trauma over and over again. Whereas reactive attachment disorder, for example, it's not necessarily the case that the individual is re experiencing the trauma. It is more the case that they have been impacted so strongly by a traumatic event that it influences how much they are able to interact with their environment and how well they are able to function. So, um, the example of the cat and the mouse in the book and some of the experiments that they did with cat and mice is a good. The mice were essentially re-experiencing what it felt like to be around the cat and being chased by the cat and feeling in danger because of the cat. Um, Whereas um, the question then becomes, what were some of the factors that related to that? Why was that occurring? And in fact, that's really one of the questions that are at the heart of the diagnosis of PTSD, which is, why do people re-experience um, the traumatic event? I brought this up, I think, in the first class, but it's worth reiterating here that certainly one of the questions you could ask when it comes to PTSD, for instance, in combat veterans, veterans who've been exposed to, the awfulness of combat. The question could be one of not, um, the question might not only be, why do some people who've been in combat experience PTSD symptoms, but you could also ask the question, the almost even more relevant question would be, why does every combat veteran not experience PTSD? I mean, given the horror of combat, and basically, when you're I've interviewed a number of different Vietnam veterans, and then later on veterans from uh, Desert Storm and Iraq and all this stuff. And it's interesting to hear from them that, you know, basically, if you're on tour for a year, you spend a year in a combat zone just being constantly worried that someone is going to kill you. And you might wonder, well, why does that experience continue for someone who's been in combat, so that they're re-experiencing over and over again? But you could also legitimately ask the question, well, why doesn't that happen with every combat veteran? Why do you not, um, how do you get over that? How do you tell your body, your brain, to sort of shut that off when you've been living in it for so long? So there were a lot of, I think what you saw in the chapter of my book over here, I think what you saw in the chapter was the number of different biochemical reactions that could explain why some people have a harder time, oh, bouncing back from the impact of a traumatic event, and why some people re-experience the traumatic event when that doesn't happen with everybody who's been exposed to a traumatic event. So a lot of what's in the material there that I will leave for you to read, and certainly ask any questions that you have when we meet, is relates to that question of, well, what happens in some situations where people just keep experiencing it? Why is that occurring? And what are some of the factors um, that enter into it? I've done a lot of evaluations on, as I said, combat veterans who've sought disability for PTSD. And what's interesting is, it's not like there is a consistency in terms of, well, when they have this sort of experience, or when they're in this sort of environment as part of their combat experience, that assures that they're going to have PTSD. I mean, there's a lot of variability in PTSD, both on individual factors and also in variability in terms of experiences and what the person had to face when they were in combat. So a lot of questions related to this overarching issue of, who develops PTSD and who does not. And again, we can talk about that more in class because it's all in the reading there. So I'd certainly want to know what sort of questions you might have about it. But let's start here with talking about the diagnostic criteria. And I have it up on my other screen here. And I'm going to go through each of the aspects here and um, talk about them in a little bit more detail. So the first is um, the person has been exposed to actual or threatened death, serious injury, or sexual violence in one of the following ways. So notice that first part: actual or threatened death, serious injury, or sexual violence. So that could mean um, uh, that they actually saw someone died, or there was the threat that someone could have died, that there could have been a traumatic event leading to another person's death, or they may have been threatened with their own death. So, um, actual or threatened death, serious injury, or sexual violence. Now, one of the reasons why threatened, why I wanted to stress that there is because it doesn't have to be that they know the person died. You know, say someone is involved in a major car crash, which could be, you know, a precipitant for PTSD. Someone is involved in a major car crash and their passenger is seriously injured. Um, that could be um, a trigger for PTSD, even if they don't know if the other person died or survived but suffered a serious injury. So, a lot of reasons why threatened death or serious injury is part of it is because the person experiencing trauma doesn't always know the outcome. They always don't know what happened, but it's that trigger of how bad they think it could have gotten, or how badly they believed um, that it had been. You know, the paramedics maybe show up and say, "Oh, this person's dead," and it turns out later that they actually survived. So it doesn't matter if the person knows that someone else died or just thought someone else died. It all comes back to the same thing: is that if there's a perception that someone died or could very well have died, that could be a trigger for PTSD. Um, let's go through the following ways: directly experiencing the traumatic event, so they're right there while it's all happening; witnessing in person the event as it occurred to others. And of course, that goes back to the first term, actual or threatened death. Of course, someone's not going to watch their own actual death because that would mean they'd be dead. So, um, it could be that something happened to them that threatened a real possibility that they could be killed, or they watched someone else actually be killed, or experience something that looked like it might have killed them. Learning that the traumatic event occurred to a close family member or friend, um, that's relatively new. It didn't used to be that that was considered part of PTSD, but learning details about something that has happened to someone close to an individual could also be a trigger for PTSD. And experiencing repeated or extreme exposure to aversive details of the traumatic event. So, uh, eh, but you'll notice with this last part, notice the last part of it. This does not apply to exposure through media such as television, movies, or pictures. Now tie that in with the third one, which says that it occurs to a close family member or friend. And you see something about PTSD that comes into light there. With PTSD, there has to be a personal connection. Um, you cannot see images of a car crash on the news, even if it's repeated over and over again, and you find it very distressing. That cannot be a a trigger for PTSD because there's not that personal connection. So a lot of the theories behind PTSD really relate back to this whole idea of it has to be a personal connection. You know, you were afraid something was going to happen to you, or something was going to happen or did happen to someone you care about or you have a personal connection with. It cannot be sort of just something terrible happening to someone else that you don't know and have no personal connection with. Uh, okay, the second part of the diagnosis, the person's response involved intense fear, helplessness, or horror. So that just underscores the whole issue of, all right, that other part just had to do with um, the feelings, a very strong emotional response to what happened. Um, so there has to be fear, horror, all those things. There has to be so there's a couple things we see from that. One is um, that what Aldo shows is there has to be a personal connection to the trauma. What happened to the person, the person that was involved in the event has to be someone that the individual has a personal connection with. Now that personal connection may be that it's themselves, that they felt that there was a real likelihood that they were going to die or be seriously injured. Um, or, and this, PTSD, um, might relate to, someone's in a car crash and they don't remember everything that happened, but someone shows them pictures later on of how horrific it was, and how terrible it was, and that can create a sense of trauma for an individual. Uh, Now, as we move on with PTSD, the traumatic event is persistently re experienced in one or more of the following ways. And notice how, there's five of them. There's multiple ways that the person may re experience event. But again, there's this issue of re experiencing um, the trauma. And I kind of I wanted to segue here. We're class nine. We're towards the end here, and I wanted to make sure that you were seeing here sort of a pattern throughout almost all of the diagnoses that we've talked about in this psychopathology course. And there's this whole idea of like repetitiveness, like someone, whether it's depression, whether it's anxiety, certainly one of the three primary symptoms of autism, PTSD. There is a sense that there is often a theme of repetitiveness. PTSD, it's persistently re-experiencing the traumatic event. Anxiety, it's repetitive negative thinking. Depression, it's uh, not being able to let something go, sort of repeatedly, the person repeatedly beating themselves up emotionally. Um, Autism, repetitive behaviors are part of the diagnosis. So there's this theme of this pattern of um, trying to stop the repetitiveness. Um, Now it's interesting. We've talked in here about eye movement desensitization, and a lot of times with therapy, the attempt to stop that repetitiveness is to work on techniques that the person can use to cognitively stop their repetitiveness. One that's used for anxiety is thought stopping, where the person literally yells to themselves and then yells to themselves in their head, stop, to stop that repetitive negative thinking. Eye movement desensitization is to try to adjust the physiological um, aspect of that repetitive thinking. That if you can get basically by changing the eye movement, um, that's often associated with a traumatic event, the thinking is you can stop the repetitive negative imagery that's often associated with PTSD. So there's this issue of repetitiveness in any across all the diagnoses of PTSD, and therapy is often geared towards trying to stop that repetitive negative thinking or negative imagery or just negative behavior. And so you see that sort of across all the diagnoses, and certainly this persistent re-experiencing, sort of getting stuck in something, stuck in negative thinking, stuck in um, experiences, stuck in behaviors, um, and not being able to move on there. And certainly a lot of the um, impact of stress that we see throughout the book is as complex as the biochemistry can be, it's often all related to, well, why do people get stuck in this pattern? And how do we break it? Now, in with psychopharmacology, with medications, it's almost like, you know, taking explosives to a bridge. You just kind of throw all these chemicals out with the hope of, blasting apart the repetition that the person has, or the persistent focus on any one type of thinking. So you sort of send these biochemical agents that are put into the body via medication with the hope of just sort of blowing up the pattern that led to the person's difficulty. Some other Now in therapy, um, you often try to address it one of two ways. You either um, get the person to cognitively work through how they're addressing things with, you know, thought stopping or alternative ways of thinking, cognitive therapy, uh, or possibly addressing the emotional roadblocks that are interfering with the person um, moving past a certain point. Um, Getting stuck on a certain place in a person's life was sort of was has been at the heart of what psychoanalysis is. Psychoanalysis is, people get stuck at certain stages in their life, and if you can break through the um, the obstacles to them moving past this repetitiveness, um, then you can help the person feel better. So with PTSD in particular, it's an attempt, cognitive therapy would be an attempt to get the person to change their thinking so that they are able to move past the memory and sort of be able to file the memory as a memory as opposed to experiencing as if it's going on. So sometime with therapy, the attempt is from the mind outward, the brain outward. With but with some other attempts at therapy for PTSD or anxiety disorders, it might be going in a different direction. Eye movement desensitization therapy is one of those, where the attempt is to address the physiological symptom associated with the repetitive re-experiencing of a negative thing, and sort of work from the outward in. That if we can change the person's physiological response, that will help change the either the thinking pattern or the memories that are going on in the head. So sometimes the difference with therapy to try to break this repetitiveness is Are you going from the mind outward or from the body inward? But either way, much of therapy is this attempt to break repetitive problematic patterns, and PTSD is no different. That there is this persistent re-experiencing of the traumatic event. Now, how can that come about? There are 5 examples I gave here. I'll go through them. Recurrent and intrusive, distressing recollections of the event. Uh, so again, recurrent thinking, recurrent images that the person has, thinking they smell or hear things that are going on, um, recurrent distressing dreams of the event. Nightmares are a common characteristic of PTSD. And notice that with the diagnosis of PTSD, only one of these has to be present. So it's not a case that you have to have flashbacks and nightmares and um, re-experiencing the situation. Could, in physiological ways, it could just be one. Acting or feeling as if the traumatic event were recurring. Um, this is similar to one, except one is just more distressing memories, and memories might bring up certain smells or sounds. Um, Number 3 here is actively smelling, hearing, or say like you actively feel like you're re-experiencing those things. Intense psychological distress at exposure to the cues that basically trigger memories of the traumatic event. Um, you know, I've interviewed individuals who had PTSD after coming back from Vietnam, and it was interesting. One was quite anxious in my office, and this is when I was seeing people in my office. Um, so it's not this office; it's my outpatient office, and he was clearly anxious, and to the point that at one point I asked him what was causing his anxiety, and over my left shoulder I had I have a plant, a large tree. It's plastic, but it's part of the decor. Um, and he was focused on that because it was a tree that looked very similar to trees he had seen when he was serving in combat. So it was bringing about a level of anxiety that he had when he was in combat, that was making it difficult for him to focus because he was so distressed about re-experiencing what he experienced when he was in combat. Uh, Now that's psychological distress. Notice how 5 comes up, and it's sort of the same thing, except it's physiological reaction. So number 4 is psychological reaction. Number 5 is physical reaction. That would be where the eye movement comes in, because the thinking is that eye movement is often associated with how people react to traumatic events, and that would be uh, that would be an example of a physiological reaction to a trigger, reminding them of the event. Um, Now, persistent next criterion, persistent avoidance of stimuli associated with the trauma, uh, and um, numbing of general responsiveness. So, one of the things I wanted to point out about this specific criterion is the part that comes after, which is not present before the trauma, because that's often, um, especially when people are seeking disability for PTSD, that's often a question that comes up, which is, was this present at all before the event occurred? So when you're talking about somebody for instance, uh, numbing of responsiveness, just not reacting strongly to emotional things, either good or bad. Um, Many people have that for other mental health reasons than PTSD. So, one question that comes up a lot in evaluations I do for PTSD is the question of, was this person like this at all before everything occurred? Um, yeah, and it goes back to this real important but unanswered question of what causes a person to have PTSD. Why does one person who's exposed to combat develop PTSD, and why does another person exposed to combat not develop PTSD? And the thinking really is pretty strongly around the idea that there are some degree of precursors to developing PTSD, but they haven't been identified. And so right now, it's an unanswered question. But there does have to at least be some clear indication when you're evaluating for someone for PTSD that this wasn't present beforehand, that there was no evidence the person was like this beforehand. So if you have somebody who appeared to have a lot of difficulties with anxiety even before they went into combat, um, then that's less likely to lead to a diagnosis of PTSD. But that's hard to tell. Usually you don't have a whole lot of data about how someone was before. Um, so that's often difficult to answer, but there at least has to be some clear indication that the person was not like this before. It may just be self-report, it may be what their family reports, but there just has to be something. Uh, so some of the ways people avoid stimuli associated with the trauma, um, they try to avoid just thinking about it or feeling it at all. And of course, trying to avoid something can cause even more anxiety. The old joke about, well, whatever you do, don't think of a pink elephant. Of course, once told that, what most people end up doing is think about a pink elephant because it got brought up. So very often, one of the when you look at these things, it's interesting to see how where the overt expression of PTSD comes in, and the second one also efforts to avoid activities, places, or people that arouse recollections of the trauma. It is in attempting to avoid something that we tend to have the most anxiety. It's interesting. What I kind of wanted to use, you see me doing this with a couple things in this lecture is kind of, since this is the last one that was on the list. I know we're going to talk about eating disorders next week, but this was the last one that we had definitely planned on talking about. It's interesting to notice that one of the ways, certainly therapy helps individuals by helping to break this sort of repetitive nature of symptomology. But there's also a degree to which therapy helps in a lot of ways just by giving the person the opportunity to say out loud something they've probably been trying to avoid thinking about or bringing up at all. Um, because sometimes just getting it out there, saying it or talking about it can be useful because it's out there and you don't and you learn that you don't have to keep fighting the memory. And if you can help the person have the memory and find ways of dealing with it effectively, that more than anything ends up helping the person in a lot of circumstances. Now, what's interesting is sometimes the person will talk about actively trying to avoid situations or other things that remind them of the traumatic event. Some will just lose the memory entirely. They just won't be able to recall much of the trauma or important aspects of the trauma. So it's almost like that anxiety kicks up and just kicks the memory out entirely. So the person can't remember much of what happened. Uh, Diminished interest in or participation in significant activities. And then the next one is feeling of detachment or estrangement from others. Notice how those two are tied together and they kind of relate to the first two. You know, diminished interest could in large part be the person just avoiding things that remind them, you know, maybe they don't like to do things with other people because it reminds them of how anxious they were around other people when they were in combat or when they were hurt, or don't like to go to activities because going to activities might mean riding in the car. And if they've been impacted by the effect of a major auto accident, then that could be where getting to events becomes anxiety provoking because it means riding in a car. uh, Feeling of detachment or estrangement from others, that could be an extension of trying to avoid social situations that might arouse feelings of what happened. Restricted range of affect could again be, sort of an extension of trying to avoid thoughts and feelings. Uh, uh, and the last one here is kind of interesting. Sense of a foreshortened future. So the person may feel like they are not going to live long. So it, if you think about what leads to um, PTSD and this sort of ongoing feeling of trauma, it is interesting to consider that PTSD most prominently occurs in combat veterans. It can occur in many other situations, but that's sort of where it got its prominence. And it is interesting to consider that it's probably not coincidental that there are a couple things about combat. One is um, it involves an almost constant feeling that you could be killed because that's literally true. That's literally what it is. Um, that there's an unpredictability to it, and that combat tends to involve younger people. Many people who suffer PTSD in combat are there in their first, second, maybe third tour of duty. If they went in when they were 18, that means they're 19, 20, 21. Uh, you don't have as much PTSD, for someone who's been in the military for 10, 20 years, and then they go to, even if they hadn't been in a combat environment before, they've been in enough situations that it doesn't come totally out of the blue. But if you think about, well, why would being young, it's probably a case, I don't have data on this, but it's probably a case PTSD is that it tends to occur quite often or more often with younger individuals. And it's at number 7 that's kind of interesting. What it really does in some ways, it says in the book here uh, uh, some of the biochemical issues that relate to PTSD. But it's interesting when you think also just a view of the world, a psychological impact of it. One is that probably plays a major role is sort of someone being hit head on with their own mortality. Oh, I really could die at any second. 18, 19-year olds don't think that way. It's sort of a standard that 18, 19-year olds feel they're invincible. The idea that you die when you're 70 to them is an eternity away. But there is this, so one sort of theory of why PTSD might occur in combat veterans and where it might come from is how much did it reflect the person coming face to face immediately with their own mortality? The just absolute reality that I could be alive one second and dead the next second and not even know it's coming. So it's interesting to think about that from a theoretical perspective because it is a major, it's not coincidental that PTSD often occurs with younger individuals, especially if it's in combat. And that number seven, a sense of a foreshortened future that I'm really probably not going to live that long because combat or traumatic car injury, anything along those lines can really bring that and shove it in a person's face. Some of the symptoms related to PTSD include difficulty falling or staying asleep, irritability. These are some of the overt symptoms. Um, Difficulty concentrating, hypervigilance, always seeming on edge, and exaggerated startle response. And then the last two, we got kind of our standard. The disturbance has to be present for at least a month, so it can't be a short term type thing. There is another diagnosis in DSM called acute stress response. Acute stress response, that's when it's less than a month, sort of the person reacting to a stressor in a very intense way, but it doesn't seem to be, uh, it doesn't last for more than a month, or it doesn't or it hasn't lasted for more than a month. Someone is in a car accident and comes in to see you for therapy, and the car accident was 2 weeks ago. That's not yet PTSD. That would be acute stress response because it's been less than a month. And of course, significantly impairs social occupation or other important areas uh, other important areas of functioning. Okay. Couple other things just about differential diagnoses. That other I talked about acute stress response. That's the one where it's less than a month. Um, uh, Personality disorders can resemble PTSD, and the one that is seen as being the most consistently the closest to in terms of resembling PTSD is borderline personality disorder. That tends to be a person who seems to always be on edge and easily agitated. Again, it's interesting to keep in mind that the difference between PTSD and borderline personality disorder is borderline personality disorder is present uh, throughout the person's life. You cannot diagnose a personality disorder unless there's evidence that it was present before 18 years of age. So, since most traumatic events that occur with PTSD occur after age 18, this is where the whole history comes into play. That if you have evidence the person's kind of always been this way, it wouldn't mean that they couldn't have developed PTSD, but it would just be that it's more borderline personality disorder. Keeping in mind that borderline personality disorder is often associated with trauma, with a history of trauma. Many people with borderline personality disorder have a history of being abused. Not always, but it tends to be. It is a common factor. So you kind of this is really where too PTSD is probably really one of the diagnoses where it becomes even more important to follow all the criteria very closely, so that you can tell if it's PTSD or borderline personality disorder. Um, PTSD is also a diagnosis where you really have to uh, come to grips with this idea of self medicating. So, so the issue um, is that um, you want to make sure. Oh, uh, you want to consider the degree to which substance abuse is impacting on the person. So very often people with PTSD will self-medicate using drugs or alcohol. It is interesting that I have seen a lot of Vietnam veterans for PTSD, but they're older now, and it's interesting that they will come in and it'll be like, well, why have you not sought disability or sought services before this? And two factors will often play a role. One is many of them took on jobs that were almost totally isolated. Truck driver is a good example. A lot of guys I've known who had PTSD. Uh, Part of how they were able to function is they worked for 30 years as a truck driver where they didn't interact with anyone. They just were in their truck all day long. But substance abuse is also another issue. A lot of times I see someone who's seeking disability for PTSD and they're just a couple of years off of, a 30-year alcohol abuse problem. And so the way they self-medicated, um, uh, the way they self-medicated um, is through alcohol, and that's how they dealt with the impact of the trauma. So they were able to function by limiting how much they interacted with other people and self-medicating using alcohol. So alcohol abuse and substance abuse is often a major problem with PTSD, and it relates to this idea of self-medicating. That rather than go get treatment to help me with this, I'm just going to drink myself into oblivion so I don't even have to bother with it. Uh, okay. So it's kind of, you went through the reading there, but this whole classical conditioning model um, comes into play with where does um, PTSD come from? And the idea that the event can lead um, to re-experiencing um, the trauma. The part almost like Pavlov's dog in to an extreme. Pavlov's dog was um, the bell rang and there was food. Bell rang, there was food, and then the bell rang, but there was no food. The dog still salivated because the physiological reaction to the event um, that had been paired with the other event kept going even when the main event was taken away. That's sort of the idea of trauma. Now, again, why it occurs with some individuals and others is unknown, especially when you consider that there is no evidence that there's a direct relationship between um, uh, the severity of the trauma and whether a person develops PTSD um, or not. Uh, the I've got a study that I pulled up here. Now it's kind of old. It's from 2001, but at the time, the stats, and this hasn't changed a whole lot, um, is that 7 to 12% of the population exposed to a trauma develops PTSD. Now, one reality of PTSD, and this is just one I'm going to throw out there because it has to be something that you keep in mind. But uh, but that number climbs to 85% when the person is presented some clear opportunity to get compensation for PTSD. So if it looks like something has happened to keep them from working and they can see a direct relationship to be able to get disability payments for having PTSD, 85% of the people who talked about um, having experienced a trauma will identify symptoms of PTSD, and that's just reality. When you're working with PTSD, you have to keep in mind, is there secondary gain from this? Is there a possibility that the person would be seeking disability payments for this? Most people get over traumas. I mean, I don't mean to say they quote unquote deal with it, or even get over it is not I apologize, that's not a good set of words to use. But they recover from the symptoms, like the traumatic symptomology uh, associated uh, with PTSD. Um, most people, those symptoms tend to abate after a month or so. The research, 8 to 12 weeks, is a sort of common time frame. Uh, so any sort of um, strong psychological reaction that people have to trauma tends to sort of dissipate over time. So really with PTSD, you're working with individuals who, for whatever reason, the effect of the trauma isn't going like this. It's just staying where it is. Um, this is where exposure therapy, cognitive behavior therapy is the most effective treatment for that. I would say EMDR probably falls under behavior therapy. It's teach behavior therapy often is more focused on helping the person learn a skill, and PTSD is uh, I mean, eye movement descent is certainly a skill that the person is learning, and so um, uh, EMDR is not one, but in general, cognitive behavior therapy plays a major role as far as being an effective treatment. Exposure therapy is where you kind of help the person learn anxiety management skills for helping them uh, uh, for helping them learn effective ways of decreasing the emotional distress related to any memory that they have of the traumatic event. So really what you're trying to help the person do is answer the question of, how do I deal with this? How do I deal with what has happened to me? Um, the traumatic event. How do I find ways of lessening the high level of emotional reaction I have to what has happened? Um, and they're really, we went through the DSM-5 criteria, and we talked about some of the events that can lead to PTSD. But again, there's this repetitive pattern of getting stuck. And the question really does become one of, when trying to explain PTSD, of why does this happen? What is it about the person or the event? And some of the types of thinking that can be associated with um, PTSD is, I talked about before, this sense of one's own mortality. I really can die at any second, be alive 1 second and dead the next second. Uh, a feeling of the unfairness of life. Why was I in this situation and other people were not? A sense of wanting to have some sort of retribution to cause difficulties for others and for yourself, um, because of the difficulties you've had to experience. Oftentimes there can be a feeling of, blaming oneself. I deserved to face this. This is all, my fault. Um, uh, I'm no good. Uh, so I need to keep re-experiencing this because I deserve all this bad stuff happening to me. So very often negative thinking can play a major role in in the symptoms of PTSD. Negative thinking about oneself and what someone has to put up with. Um, when thinking about this, it can be interesting to keep in mind. I have a list here of some of the risk factors that can be associated with PTSD. Um, a history of traumatic events can put someone at danger for PTSD. So it's interesting to keep in mind how PTSD is often thought of just having one traumatic event, but there is some thinking that well, it could be that there is a series of traumatic events that the person has had to suffer throughout their life, but that the one sort of trigger event was the the sort of straw that broke the camel's back, so to speak. So it's interesting to consider how it can be more complex than just everything's going along fine, then the person has a traumatic event, and then everything's not going fine. It could be that there's a building effect, that it could be that the person suffered from other less severe traumatic events. History of physical or sexual abuse can put the person at risk for PTSD, and that means not the physical or sexual abuse that directly relates to the PTSD that the person re experiences, but again, this whole idea of um, maybe there being a stepwise progression to when someone develops PTSD. History of substance abuse, history of depression, anxiety, or other mental illness. Notice how there's a history part to that, suggesting again that the person's ability to deal with the trigger traumatic event may sort of be that other things were going on in their life that were kind of chipping away at their ability to deal with major events. Other risk factors: high level of stress in everyday life, lack of support after the trauma, and lack of coping skills. And what I really wanted to get to, as far as those last two things, is it's important to keep in mind um, how useful it can be um, uh, for um, for how useful it can be to get the person treatment as soon as possible after a traumatic event. There is something called crisis um, desensitization training. Uh, I'm sorry, critical incident desensitization skills, or um, and that is an approach that often is used after traumatic events, often to a group. I've been asked to do some of them, where a psychologist who is an expert in PTSD will come in and talk to the whole group and sort of help them desensitize after uh, the trauma. So a traumatic event happens, and then they'll send in someone to do this critical incident debriefing, and basically it's a way of sort of preventing helping the people learn skills right at the moment to help them deal with the impact of trauma. Um, when I've been asked to do it, it's interesting. The times I've been asked to do it, it's always been the same situation. It's been a bank where there was a robbery, and once or twice it was a robbery where someone was killed, and so I was asked to come in and do a critical desensitization training with the whole staff. These individuals had not developed PTSD, but it's a way of providing support and helping them learn skills to prevent PTSD from occurring. So there is a whole lot of theory these days, as far as therapy goes, that you can actually prevent PTSD by helping people get assistance as soon after the traumatic event as possible. I know we're running a few minutes over the hour, but I did want to talk about one last thing. I thought this was kind of neat. I've seen this in presentation, that there is a sort of acronym for helping to keep in mind the symptoms of PTSD, and the acronym is the word DREAMS, DREAMS, and it stands for this. D is detachment, separating from uh, social interactions. R is re experiencing the event. E is the event had emotional effects. A is avoidance. M is month in duration. And S is sympathetic hyperactivity or hypervigilance. Sympathetic meaning the sympathetic nervous system. That's where you would see hyperactivity or hypervigilance, the person being on edge. So DREAMS, detachment, re experiencing the event had emotional effects, avoidance, month in duration, sympathetic hyperactivity or hypervigilance. And those are all, that's just a little memory device for helping you uh, gain a better sense of what um, is needed in order to diagnose PTSD. Okay, we'll stop there and I'll look forward to seeing you on Thursday. Take care.